Good morning, everyone. Today I'll be presenting a journal club. In the journal club, I'll be presenting a review article titled Imaging After Pancreatic Surgery Expected Findings and Post-Operative Complications. This review article has been published in the Journal of Radiographics, which is the topmost journal of radiology. And it is a very recent publication, published just in this month, December 2023. So the article covers four main topics. First, the initial part, the article talks about various types of surgeries that are done for the pancreas. In the second part, it talks about what are the expected post-surgical changes after a pancreatic surgery. In the third part, it talks about various complications, something which is not normal. So it talks about the complications after a pancreatic surgery. And in between, it shares some tips how to differentiate the normal from abnormal. What is normal after pancreatic surgery and what is abnormal after pancreatic surgery. So pancreatic surgery is one of the most complicated surgeries in the abdomen, and pancreatic surgery leads to a lot of morbidity in the patient because the pancreas has both exocrine and endocrine function. So any damage to the pancreas greatly affects a patient life. And the choice of surgery, which surgery is done, mainly depends on two factors. The first is the nature of the lesion. So whether the lesion is a neoplastic condition such as a pancreatic tumor, and most of the surgeries are done for a pancreatic tumor, but sometimes surgeries may also be done for an inflammatory cause, such as for chronic pancreatitis, which is not responding to medical management. Certain surgeries can be done, and for acute pancreatitis and chronic pancreatitis, certain drainage procedures can be done in order to remove the necrosis and any peripancreatic fluid. Other factor which influences the choice of surgery is the site of the lesion, whether the tumor lies in the head of the pancreas or it lies in the body and tail of the pancreas. This is important because the head and the body and tail of the pancreas have different arterial supply. The head is mainly supplied from the gastroduodenal artery and the superior mesenteric artery. They give the superior and inferior pancreatic branches which supply the head of the pancreas. The body and the tail are mainly supplied by the dorsal pancreatic artery, which is a branch of splenic artery. The various imaging modalities that are used to assess post pancreatic uh, uh, complications include multiphasic CT, because in multiphasic CT we can see the entire cross sectional imaging of the pancreatic bed. We can see the vessels, we can see the bowel, we can see the bile duct, we can see the pancreatic remnant. All the anastomosis can be seen. So the multiphasic CT is the imaging modality of choice. MRI can be sometimes be used because MRI gives a good picture of the hepatobiliary system. So the hepatic duct and the main pancreatic duct are seen well on MRI. Fluoroscopy is mainly used to see the bowel. So a barium meal or a bilium meal follow through. These can be done in order to detect any anastomotic leaks or any strictures. Ultrasound is mainly used to guide drainage procedures for acute pancreatitis, and sometimes nuclears can be done for to look for the biliary tree. Now, various choices for the pancreatic surgery. So the most common surgery that we know it is Whipple surgery, which is pancreatic duodenectomy. In this, the head and uncinate process of the pancreas, the CBD, the common bile duct, the duodenum, and the gastric antrum or pylorus is removed, and a jejunum is connected to all the remaining structures. And there are three anastomosis in this case. One is the pancreaticojejunostomy anastomosis, one is the hepaticojejunostomy, and the third is the gastrojejunostomy. So there are three anastomosis. So we have to pay attention to all the three anastomosis. So it is very important to know which surgery has been done for this patient. When we see a post-operative imaging CT of the pancreas, then we must know which surgery has been done, because only then we know that which all anastomosis is created, and then we have to pay attention to which anastomotic site is pathological, if all the anastomosis is working properly or not. Another common surgery is distal pancreatectomy. When the lesion is in the body and the tail of the pancreas, a distal pancreatectomy with or without splenectomy can be done. Like in this case, a tumor in the central portion of the pancreas, a central chondrontectomy can be done. But this approach is not generally favored because, as we can see, that in pancreatic duodenectomy, distal pancreatitis, there is one single suture line in the pancreas. But in central chondrontectomy, there are two suture lines. One is here at the site of pancreatic jejunostomy, one is here in the pancreatic remnant head. So the more the number of suture line, the more the chances of a leak of pancreatic enzyme. So this is not generally preferred. And if there are multiple tumors or the tumor is diffusely involving the pancreas, a total pancreatectomy can be done. For chronic pancreatitis, also we can do some. If it is not responding to medical management, the surgeon can do certain surgeries, like they can do a lateral pancreatic jejunostomy in which the main pancreatic duct is cut open and it is anastomosed to a loop of jejunum. Phrase procedure is also the same as Puster procedure, except that in phrase procedure, coating of the head of the pancreas is also done. So that's that the head portion also drains well. And Bejer procedure is basically as similar to Frey procedure, but in this, a head and a portion of uncinate process of pancreas is spared in order to prevent biliary complications from occurring. Certain drainage procedures can be done for acute pancreatitis, such as percutaneous vein insertion, necrosectomy for ward of necrosis, and cystgastrostomy, cystoduodenostomy, and cystogenostomy. These are basically endoscopic procedures for pancreatic pseudocyst. Now, what are the expected post-operative changes after pancreatitis? So these changes are totally normal. They should not be interpreted as misinterpreted as abnormal findings, and so we must learn about what is normal. So in the early phase, in the first 3 months of surgery, small amount of extraluminal air which is stable or it is resolving. So small locules of air can be seen in the first week after surgery. We may see small amount of fat stranding. The surgical site edema can be present. Perivascular cuffing, a rim of soft tissue around the vessels, is a normal finding. Pneumobilia can occur after surgery because we are doing a hepaticojejunostomy. So the pneumobilia can actually persist late in the late phases also after pancreatic surgery. Certain prominent lymph nodes can be seen in the pancreatic bed, and seroma or can form. So seroma is basically a sterile collection which is totally harmless, and it can form after a pancreatic surgery and it will resolve slowly. The late changes include parenchymal atrophy. So after a surgery, the pancreatic remnant can undergo atrophy, and pancreatic duct dilatation can also occur. So it is said that once the pancreatic duct dilates due to a tumor or any due to chronic pancreatitis, even after surgery, the duct will remain dilated. The duct will not reverse to normal. Post-operative scarring can occur in the surgical bed, and post-operative scarring can actually mimic recurrent tumors. So many times we may not be able to differentiate scarring from recurrent tumor, and we may need to do a biopsy. Prominent lymph nodes may also be seen in the late stages. Now, this is a case of perivascular cuffing. So, this after a Whipple's pancreaticoduodenal distal pancreatectomy with a splenectomy has been done in this case, and we can see that there's a rim of soft tissue around the vessels around the superior mesenteric artery, and this is a totally normal finding. So, this is an expected post-operative finding after pancreatic surgery. In this case, we can see certain prominent lymph nodes in the surgical bed, and there is a mesenteric haziness, which indicates that there is surgical site edema. And on follow-up, we see that these lymph nodes remain stable, and the mesenteric edema has also resolved. So these are normal expected findings after pancreatic surgery. Now here we can see that there is some soft tissue enhancing lesion here anterior to the vessels in the pancreatic bed, but this can really mimic a recurrent tumor, but this remained stable on follow-up. So this was nothing, just post-operative scarring. Now, complications of pancreatitis, something which is not normal, which should not occur after pancreatic surgery. So the complications can be divided into those complications which are localized to the pancreatic bed and those complications which are away from the pancreatic bed. Localized to pancreatic bed includes complications arising out of the pancreas, which is pancreatic leak. And pancreatic leak is one of the most dreaded complications of pancreatitis. Sometimes fistulas can form between the pancreas and the skin. Recurrent pancreatitis can occur after pancreatic surgery due to iatrogenic pancreatitis, and complications can be related to the anastomotic site, that is the pancreaticojejunostomy site. Similarly, complications can be related to the hepaticojejunostomy site and to the gastrojejunostomy site. Other complications apart from pancreatic bed includes biliary complications, vascular complications in which there can be vascular erosions, aneurysm formations, and enteric complications related to the gastrojejunostomy site, and some other complications such as abscess and tumor recurrence. We'll see all these complications one by one. So the authors in this article have described various types of fluid collections which can form after a pancreatic surgery. The most common fluid collection which forms after pancreatic surgery is transient post-surgical collection. But other collections can also form, such as pancreatic leak, bile leak, gastrojejunostomy site leak. So as I told, we are forming three anastomosis: pancreaticojejunostomy, hepaticojejunostomy, and gastrojejunostomy. So all these three anastomotic sites can leak, and we'll see later how to differentiate the leaks from all these three sites. Hemorrhage can also present as a fluid collection after pancreatic surgery, an abscess. So if any of the above collection gets infected, an abscess can also form. Now, transient post-surgical collection, unfortunately, we do not, the authors have not provided a picture for this, so I have not added it. But transient post-surgical collections are basically seroma formation, and these are benign collections. They are small volume collections. They remain stable, or they regress on follow-up, but they will never increase. And no significant inflammation is seen surrounding these collections. There's no rim enhancement, because rim enhancement basically indicates that there is a collection inflammation going on. So there's no inflammation around it. And these collections do not have any fat foci within them. In contrast, pancreatic leaks are pathological collections. So this was a neuroendocrine tumor of the pancreas for which pancreatectomy was done, distal pancreatectomy. And this we can see that after the surgical surgery, there's a large collection, and there's also a lot of inflammation around this collection. So this is definitely a pathological collection and not just a carcinoma. And we can see fat foci in this collection. So fat foci indicates fat necrosis. So this is a pancreatic leak because the pancreatic enzymes contain strong proteolytic enzymes. So they will lead to a lot of inflammation and fat necrosis around them. So, and if we do an aspirate this fluid, and we do analysis of the aspirate amylase levels, then that will be more than 3 times that of serum levels. So aspirate serum as analysis of amylase level analysis of aspirate is important in deciding whether it is pancreatic leak or another other collection. This is pancreatic or jejunostomy site, and where we can see that the site has become dehiscent. The sites have broken off. There is some suture material. There's fluid and air foci, which indicates that the site is dehiscent. So dehiscent means there's pancreatic leak. There's dehiscence, the pancreatic enzymes will leak out. Bile leak. So bile leak can occur due to dehiscence of the hepatic or jejunostomy site, and in that case, we'll get bile in the drain, and in the fluid we aspirate it, or the drain fluid we do a analysis of the bilirubin level. We find that the bilirubin level will be very high, which will be more than 3 times of serum bilirubin levels. And imaging wise, we'll see a collection around the hepatic or jejunostomy site, but for specific imaging, we can go for hepatobiliary contrast MRI. So gadoxetic acid and gadobinate, these are two contrast agents which have a hepatobiliary phase in addition to the 3 typical phases, which is arterial phase, portal phase, and venous phase. So it also has a hepatobiliary phase in which the contrast is excreted into the bile ducts. So we can see that the leak is arising out of the bile ducts if we use these MRI contrast agents. We can also use a nuclear scan, which is 99 duplication HEDA scan, which can also demonstrate the bile leak. Gastrojejunostomy site leak can also occur, and in that case, we can see some extra luminal layer. We can see air fluid levels also. If we give an oral contrast agent on CT or maybe on a barium meal, we can see the leak of the oral contrast through the gastrojejunostomy site. And sometimes on CT, we can see the dehiscent gastrojejunostomy site. There'll be dehiscence, and there will be fluid and air at the site of anastomosis. Hemorrhage can also present as a fluid collection, but hemorrhage will be hyperdense or non-contrasticity. And in the arterial phase, we can even see sometimes active extravasation of contrast, and the drain will show frank blood. So this is a catheter angiography, and we can see that there's a new pseudonism here, and there's some active contrast extravasation leading to hemorrhage in the surgical bed. Abscess, so any of the above collections can get infected and they can form an abscess. In this case, we can see an abscess is rim enhancing. In this, we can see that this collection is rim enhancing. And if we do an aspirate analysis, so we can culture it and we can see that it is infected. Post-surgical pancreatitis can also occur. So here a Whipple's procedure has been done, and after Whipple's procedure, we can see that there is some inflammation on the pancreas. So how to differentiate it from normal post-operative fat stranding? So this is not just fat stranding. The pancreas is also enlarged in size. So this is actually an acute interstitial pancreatitis. So any enlargement of the pancreas after a surgery is indicative of pancreatitis, and also, of course, in serum also we'll find increased blood amylase lipase levels. In pancreatic jejunostomy site can develop a stricture. So in case of stricture, we'll see that the main pancreatic duct is dilated and it is abruptly cut off at the site of jejunostomy. And also another finding is that progressive ductal dilatation. So duct can remain dilated after a pancreatic surgery, but if the duct is progressively dilating, it indicates that there is a stricture at the pancreatic jejunostomy site. Here we can see that endoscopy has been done, and this is the stricture site, and a balloon and assisted dilatation of this stricture was done. Hepaticojejunostomy site can also form a structure. So there's the hepaticojejunostomy, and we can see that the common hepatic duct and the biliary radicals are dilated, which indicates that there's a stricture over here. And this image, we see that at the site of hepaticojejunostomy, the CHD, the walls are thickened and enhancing, which indicates that there's some component of cholangitis also. Vascular complications. So mainly the vascular complication is hemorrhage, and hemorrhage can occur in the early hemorrhage within first 24 hours of surgery, or late hemorrhage after 24 hours of surgery. Early hemorrhage is generally due to inadequate hemostasis, ligature slippage, or it can be due to fresh bleeding from surgical site. Whereas late hemorrhage occurs due to vascular erosions. Then vascular erosions occurs due to pancreatic leak. Late hemorrhages can also occur due to pseudoaneurysm formation, and sometimes even anastomotic. At the sites of anastomosis, there can be ulcers which are bleeding. So, and vascular thrombosis can also occur after surgery. So, this is a collection in the pancreatic bed after pancreatic surgery, and we can see filling defects in the superior mesenteric vein and in the splenic vein. So, the most common vessel to thrombose is the portal vein after surgery, and then splenic vein and sometimes superior mesenteric vein can also thrombose. Pseudoaneurysms can form, mainly they are formed due to vascular pancreatic leak. So this is as a ductal adenocarcinoma which was resected, but then the patient presented with an aneurysm of the gastrohepatic trunk. So this patient had the variant anatomy in which both the left gastric artery and the common hepatic artery were arising from a common trunk from the celiac axis, and there was a pseudoaneurysm. In this, we can see that there's extravasation of contrast from the pseudoaneurysm, and then a coiling was done, and all the extravasation is now stopped. Organ infarcts, ischemia, so vascular thrombosis and stenosis can lead to ischemia. In this image, I have shown that there is a portal vein thrombosis and there is a lot of liver infarcts, large liver infarcts. But we know that liver doesn't infarct so easily because liver has a dual supply, such as it gets a blood supply from both the portal vein as well as the hepatic artery. But the biliary system, the bile duct, the common hepatic duct, it has a single supply. It gets a supply only from the hepatic artery. So if it is not supplied with the portal vein, so if there's any occlusion or stenosis of the hepatic artery or an injury to the hepatic artery, then the biliary tree can develop ischemic strictures. So we have to pay attention to that. Coming to various enteric complications. So the most common enteric complication, delayed gastric emptying. It is one of the most common complication. And on CT, we'll see a large dilated stomach with food residue. And the diagnosis can be confirmed by barium meal follow through, barium meal studies, because it will show delayed transit time in the stomach. Gastrojejunostomy site can also leak. So here we can see that there's a defect at the gastrojejunostomy, and then there's the air fluid level. So remember, air fluid level is always pathological. Small locules of flares in the first week of after surgery is normal, but our air fluid level, and especially where here we are seeing the defect also, it's always abnormal. Now, one question that which is leak is most common: hepaticojejunostomy leak, or gastrojejunostomy anastomotic leak, or pancreaticojejunostomy leak. So the most common leak is pancreaticojejunostomy leak. The pancreatic leak is most common. Actually, gastrojejunostomy leak is quite rare. Another question which they have and the authors have raised is in which surgery pancreatic leak is more common? Whether leak is more common in Whipple surgery or distal pancreatectomy? So the answer is that, and the reason for the answer is not given properly in the literature, but they have said that distal pancreatectomy has more chances of pancreatic leak than Whipple surgery. But when leak occurs in distal pancreatectomy, the leak is less severe. Whereas if leak occurs in Whipple surgery, the less leak is more severe. The gastrojejunostomy site can also develop a stricture in which stomach will be so much dilated. Patient will have postprandial pain and vomiting, but we will see a dilated stomach on cross-sectional imaging. But the imaging modality of choice for diagnosis of stricture is endoscopy, and we should be cautious about a very rare risk of development of gastric adenocarcinoma at the sites of gastrojejunal anastomosis. Marginal ulcers can form in the jejunum. So what are marginal ulcers? Marginal ulcers are formed in the jejunum at or just distal to the site of gastrojejunostomy, and they form due to the exposure of the jejunal mucosa to the acidic contents of the stomach. So on imaging, we can at most see some bowel wall thickening or some fat stranding around the gastrojejunal anastomosis site. And of course, endoscopy will be the imaging modality of choice, and it will show the ulcers. Another complication is afferent limb syndrome. So what is afferent limb and which is efferent limb? So the limb which is after a surgery, the limb which is draining the pancreaticobiliary system. So the pancreaticobiliary limb is the efferent limb, and the limb which comes off after the gastrojejunectomy site is the efferent limb. So in this, we can see that the pancreaticobiliary limb is dilated. So this is the efferent limb syndrome, and when it gets dilated, it can dilate due to edema, surgical post-surgical edema, or it can occur dilate due to strictures or due to some adhesions formation after surgery. But whenever it get dilated, it is type of closed loop dilatation, closed loop obstruction. So we can see there's a closed loop which is very dangerous. So the bowel can also perforate. It can compress the biliary and can lead to cholangitis. It can also compress the main pancreatic duct and can lead to pancreatitis. Like in this case, we can see that patient has also developed pancreatitis. And not to forget, last but not the least, tumor recurrence is a very known complication. So this is a mucinous adenocarcinoma of the pancreas, which was resected, but years later, patient presented with similar looking deposits, which were similar looking to the original tumor. And this was a port site of the patient. So patient underwent a laparoscopic surgery, and this was a port site. So tumor seeding has occurred along the port site. And such tumor seedings can also occur at the sites of needle track, along with biopsy was done, or along the sites of both percutaneous drain insertion. Sometimes tumor recurrence can present as a hepatic mets, or as regional lymphadenopathy, or as a liver mets, or as a peritoneal deposit. So it can occur in many ways. So we have to keep an eye for that. Thank you.